Hello, Dr. Kolcaba. Thank you for meeting with me today. My name is Christa Kydd. I'm an RN working in a busy rural emergency department. I would like to give some background for our listeners today. Dr. Katharine Kolcaba developed the theory of comfort. This is a mid-range theory. Her journey began while working on a dementia care unit while pursuing further education. During this time, she began to think more deeply about the phenomenon of comfort. She realized through doing the concept analysis of comfort with her husband, a philosopher, the area of comfort lacked written knowledge. Moreover, Kolcaba saw that the patient's comfort was often mentioned in care needs, but never developed further. Kolcaba realized that comfort was a universal need and treating it was holistic for patients and families alike. The theory has developed over many years and is now in the book format as of 2003. This theory gained a lot of traction and has been utilized in practice environments, studies, and is noted to have propelled further research in many areas of nursing. The theory is comprised of 4 categories: physical, psychospiritual, environmental, and socioculture. These are met once the patient goes through relief, ease, and transcendence. Dr. Kolcaba, I have a practice scenario question. How was it working with your husband, a philosopher, on the early stages of what would later turn into the comfort theory? I am asking this question because your theory not only highlights what can be felt, seen, and heard, it also deals with the unknown and what the meaning of life is to the patient, what happens when we die, which appear to be more philosophical in nature. Was this a result of his philosophical influence? You discussed how the development of your theory came about while working in a dementia care unit. I am asking this question because working with dementia patients makes it challenging to tease out what the comfort need is. I had a patient last week who was suffering from dementia, but in the hospital for congestive heart failure, and continued to remove oxygen, making her hypoxic. If the patient can't articulate what is needed and other physiological markers are not there, do you just attempt to work through the 4 categories and reattempt many interventions to see if the patient presents more at ease? This has been my practice. During my research for this paper, I read often how comfort was a complex phenomena. Still, you were able to hone in on 4 categories to identify and support a person's comfort needs. I'm asking this because this showcases a tie to the nursing meta paradigm. Within the comfort line, you discuss the use of your theory to facilitate and tease out a nurse's comfort level. Upon reading the rationale and areas to assess, this really piqued my interest on how this could really be impactful for many organizations. However, you went on to state that you never published this idea any further. I'm asking this question because of the current nursing shortage globally and the inability for educational systems to keep pace with this. Do you think you might revisit this portion and develop it further? Lastly, how do nurses apply your theory and meet all the comfort needs of a patient while working in a bustling ED, often void of resources? I'm asking this question because this is often the reality of the ED and it can be quite challenging. Thank you, Dr. Kolcaba, for your time today.